Good morning, and welcome to the Society for Academic Emergency Medicine SAEM20 virtual meeting. I am Dr. Jim Holmes, SAEM President. SAEM is the premier international organization representing researchers and educators in emergency medicine. In our work, SAEM promotes and facilitates scientific discovery, educational innovation, and the professional and leadership development of our members. Today, we are proud to bring you a medical education keynote entitled Efficiencies in Education, How to Hack Educational Training to Get from 10,000 Hours to 100 Hours. During this presentation and during our questions and answers session, you will hear from Dr. Jonathan Sherbino. Dr. Sherbino is the Assistant Dean of Health Professions Education Research and Faculty of Health Sciences at McMaster University in Ontario, Canada. He is also a Professor of Medicine at McMaster University. Dr. Sherbino is the past chair of the Specialty Committee for Emergency Medicine, Royal College of Physicians and Surgeons of Canada. He is a clinical educator, co-editor of the CanMed's 2015 framework, and co-host of the Key Literature and Medical Education podcast. He has published over 135 papers and 5 books. Jonathan is an award-winning teacher whose accolades include the National 2018 Canadian Emergency Medicine Teacher of the Year. His research focuses on competency-based medical education. He will be sharing evidence-informed techniques to improve learning efficiency with your institution. During the presentation, you may submit questions for Dr. Sherbino by clicking the Q&A button in your Zoom menu interface. Questions that are upvoted will be prioritized during our questions and answer session to start immediately after his presentation has concluded. I would now like to introduce Dr. Jonathan Sherbino. Welcome to you, and thank you for joining us today.
Thanks, Jim, for that very kind introduction. Probably the most important thing for our audience to know is that I'm also a full-time clinician. And so in that, I am an active faculty member in our residency training programs, and I'm thinking about how do I maintain my own competence? How do I acquire new knowledge many years post-graduation? And so I hope that this conversation that we have today is not one that is abstract or based from an ivory tower, but in fact is very practical and implementable today and in your future practice and in your roles in different education training programs. I'd also like to extend a thanks to the Society for Academic Emergency Medicine and the leadership there for giving me this opportunity to share my perspectives on important education theory that we can make practical and implementable. Next slide, please. Certainly in the course of our hour together, the ability to drill down into some of these complex ideas will be limited. And so I'm giving you more of an overview, recognizing that some of you will be more interested in understanding further theory or getting more of a background explanation. This URL or this QR code will provide you a number of resources from the empirical evidence of experimental trials to narrative or systematic reviews. There's podcasts, there's infographics, whatever will be helpful for you and for your practice. Next slide. And before we begin, just a comment on disclosure. I have nothing to disclose. I have no conflicts of interest. Certainly my spouse is wondering why I chose to be an education scientist, because we don't get to rub shoulders with industry in any particular way. Next slide. My title of this presentation does involve a bit of clickbait. The idea of 10,000 hours is one that's in the common literature and in the popular media. And there's an assumption, I think, that we imagine that expertise comes with prolonged dwell times. And if you think back to your own residency training, or if you're a resident today and you're looking forward to the interminable hours of rotations and shifts, it does feel like the magic in education is just be there for a long time. But in fact, this 10,000 hour rule, popularized by Malcolm Gladwell in his New York Times bestseller, Outliers, originally stems from the work of Anders Ericsson. And this is a portion of Anders' work here, and it suggests that this 10,000 hours, in fact, is a misnomer. The black bars represent chess masters, the elite of the elite. And the distribution, although non-parametric, certainly shows that a number of chess masters achieved excellence and supremacy over this content area in under 2,000 hours. Others took more than 22,000 hours. And so we see a range in a distribution. There's not a cut, fast, milestone that 10,000 hours suddenly makes you an expert in any domain. And so while there certainly is individual characteristics that are unique and our genetics probably play a role, I would like to suggest to all of us that there's elements in how we deliver education and how we optimize the environment for learning that can allow us to not simply say, I have to be here for 10,000 hours to simply acquire expertise. There's moments for efficiency and effectiveness, and we should be attuned to those moments. Next slide. I want to share with you 5 key principles, and they're not processes, and I make this distinction this way. I'm not going to tell you what to do, but I am going to show you key ideas from the literature that are informed by theory and suggest to you that if you can think about the uniqueness of your own context, the needs that you have, how you can influence your training programs, then you can figure out how to make these work. You can figure out the process. You can figure out how to operationalize them. And so let's start with these idea of the 5 key principles. Next slide. AI seems to be all the rage in everything you read, and there seems to be an assumption that the way a computer works is analogous to how the brain works. And although there are features that are common, it's not a perfect one-to-one analogy. We might like to imagine that I can simply click and drag or cut and paste, and as a teacher, I can upload into the mind of my student all that I want to share with them. Here is the 10 things you must do in managing hyperkalemia. Wait for the upload, and when that's complete, that student suddenly has acquired that knowledge. And in fact, nothing could be further from the truth. Next slide. This is a cognitivist model. It's called the modal model of memory. It has been critiqued for being perhaps simplistic, and we won't get into all the details here. But this model, based on the empiric evidence that we have, suggests that the vast majority of stimulus that we encounter in every moment and in every day, we lose track of, we ignore, we pay no attention to. For that, a small amount of stimulus that makes its way into our working memory, we attend to it and we code it into our long-term memory. And so in the absence of alcoholism or stroke or traumatic brain injury, we have an infinite capacity for storage. But what is important for us to understand is that the way we code it is unique to us. It's not a perfect mirroring. It's not an exact replication. And in fact, we are informed by our previous experience, by what we know, and by what we prioritize and what we pay attention to and what we emphasize. And so you give me, here's the 10 things you must remember in the management of hyperkalemia. And how I create that node in my long-term memory is not an exact replication. Now, certainly there's not a lot of variation you can have in how you might manage hyperkalemia. And so when we look at how you represent it, there could be a significant degree of overlap. But when we get into more complex, more nuanced, more messy problems about how we might manage a problem in emergency medicine, that overlap starts to space. So what does this mean for us? When we encounter material, we do not simply upload it into our mind as a direct representation. When we teach and when we engage our learners, the same phenomenon doesn't happen. Next slide. The key idea is that we do not simply transfer information, we construct it in a personalized and an idiosyncratic way for each of us. Constructivism, an inductive theory, would offer a compelling supporting argument that says we don't have any one perfect view of reality, but we encounter reality, we try to make meaning of it, and in that sense meaning, we test and generate hypotheses, and we create a representation in the way that we think best represents that external world. And so it's important for us to understand there's not one copy of how to do everything, but rather multiple ways of understanding, making sense, and representing information. How that impacts your learning and how that impacts how you function as a teacher, you need to understand what will be the changes in the processes that you want to make. Next slide. This is a trauma suite where I practice. I'm also a trauma physician. This is after caring for one of my patients. This is a wicked problem. Kind problems are one where there's a very short and linear connection from A to B, where the feedback is automated, where the guardrails are very tight, and where it becomes very clear that if you don't choose option A, it doesn't lead to option B. And the system is well imbued to make that apparent and clear. That is not emergency medicine. Emergency medicine is not kind, and in fact, it is wicked. And so too often and too frequently we assume that simply by having your 10,000 hours of exposure where we dump you into these complex and chaotic messes, that somehow over time you will acquire experience. The further can be from the truth. Next slide. In fact, what we need is a process of specific and immediate feedback for these complex and wicked environments. When we look at how we might want to integrate the management of the polytraumatized patient, the process would not be to simply let our learners into that environment and provide no feedback. The assumptions on their decision and the outcomes of those would not typically be provided to them. And so they can continue forward in a trial and error process that never actually shows them what the error looks like. Some of us suggest that the process is one of ATLS. And I'm not here to deconstruct the challenges of ATLS. Certainly for the novice, how we can give a structure is very appropriate. But you as an expert practicing and managing the resuscitation of this polytraumatized patient, do not use an algorithm. Certainly the work of Gary Klein and his recognition prime decision-making, which would suggest that whether you're a fire captain or a physician, the use of an algorithm is not part of the decision-making and processing that you use in these complex environments. So what do we need? We need a process to get them from ATLS to the expertise that is unconscious in our practice. That first one is deliberate practice. What Anders Ericsson would say is the hallmark of acquiring expertise. Performance with immediate, specific feedback on things to change, to maintain, or to add. So let's be thoughtful how we are as a teacher. But an improved model of that is one of mastery learning. When you take the complex task of managing a polytraumatized patient and breaking it down into the sub-units that are all collectively informing that bigger task. And so you allow the learner to work on that fundamental skill set, continually working on it to acquire mastery there before the next intermediate layer is added upon and suddenly the task becomes more complex. In doing so, we make the bite that a learner needs to take much more manageable. They have an opportunity to kind of continually wrestle with the fundamental pieces before they need to add a layer of complexity, before they add the final and master layer. This is the magic of simulation. We can deconstruct really complex tasks in their constituent parts, allow regular practice in a safe fashion to acquire ability, and then layer on complexity so that the jump is one that is manageable rather than one that is impossible. Emergency medicine is a wicked environment. Simply being present without feedback will ensure that it takes far more than 10,000 hours to ever acquire expertise. Next task. I appreciate the irony of what I'm going to say next, but too frequently our educational interventions are one that is just in time, a single intervention. We say, okay, somewhere in our curriculum, we need our trainees to be able to break bad news. So I'm going to schedule 90 minutes into this session, sign off on the curriculum blueprint, and there you have it. Or likewise, I'm going to prepare for this re-credentialing exam by cramming in the final days and hours before the exam to get something there that's loosely understood or held so that perhaps I can have a little bit of recognition when it's time to engage in that material. I get it. Here I am doing rounds as a single intervention. Hopefully you'll engage with some of the other materials so that you can benefit from a process that looks at the value of spaced repetition. Next slide. 19th century physiologist Ebbinghaus demonstrated that our inability to access material was a function of time. Now, I've already suggested to you that our long-term memory, unless we injure it somehow, has an infinite capacity and we don't necessarily forget. What we are challenged to do is bring that node of information from our long-term memory into our working memory so that we can engage, turn with it, and apply it to the challenge and task at hand. The way that we do that is we build multiple synapses and build a network to access that node. That we ideally encounter it in multiple formats so that we can see the problem from a number of different angles. The actual patient presentation, the expert explanation via lecture, study materials, the podcast, all of which are articulating different elements from different perspectives of an idea, spacing over time with the interval increasing with time, so that when we go to access that information at the bedside in the care of our patients, we don't have a single synapse into that node where we struggle to find the way in, but we have multiple paths and a network to access that information to recall it quickly. Next slide. In fact, what we would love to do if we could be very efficient and hack our training programs is structure a spiral model of curriculum, where our first pass of the information looks at it in fairly wide, broad bite, but not with any significant depth, more of a superficial, returning to it again to add complexity, and then finally again for a much deeper and much more nuanced and rich version. The instruction I give to the incoming residents is to get the thinnest, smallest study guide of emergency medicine and pay attention only to the cardinal presentations. That's not to say mass casualty or environmental emergencies are not worthy, but on that first pass, I want to not overwhelm the ability to work on other processes and get a fundamental understanding of the diagnostic and management criteria for common presentations. When you return to it in the second pass in the subsequent year, then we start adding on the mimics, then we start adding on physiology. And then in Canada, because I guess it's cold here all the time and our brains don't work as quick, it takes up to 5 years for our specialist emergency physicians to graduate. So in those multiple spirals down, each time returning to information in a spaced process, we add increasing complexity so that at the end of this training process, we truly have a rich, broad, and deep understanding of how the key and cardinal information relevant to emergency medicine is established. Next slide. To sustain learning, a single vaccination is inefficient. We need re-inoculation. So what have we heard so far? We don't simply upload information, we actually construct meaning. We encounter, attend to, and make connections with what we already know. Emergency medicine is a wicked problem, and so, or the environment of emergency medicine is a wicked problem. And so we require immediate feedback, ideally sequenced in such a way so that that feedback is progressive from the very novice to the intermediate to the expert. And then if you believe that a single intervention, reading a single paper, going to a single lecture, irony, focusing on a topic in a single setting will ensure that you have a robust recall of that information down the line, you may be impaired. We need re-inoculation. The concepts of spaced repetition and spiral curriculum. How are you implementing processes for your own learning and for your engagement with your training programs? Next slide. One of the things that probably was the hallmark of my own training in education, and perhaps a function of the fact that as physicians, we are some element almost professional learners. We've been in primary and secondary and undergraduate and medical school and residency training, and for some of us graduate school, and we have acquired patterns that mimic what we've always done. Now, the evolutionary pressure has ensured that some of those practices actually are best practice. We may not know which ones are those. Other practices are simply the things that we do because we've always done that. And if there's one thing that I would encourage you to recall from this, is that if you have a practice of learning that involves a highlighter, then throw it out. If you were to look at my study notes from residency, you would see textbooks that were just rainbow, elegantly colored, showing a dedication that I returned to the same page time and time again with a new color and a new code and a new schema. And if you didn't suffer a seizure looking at those textbooks, then good for you. Next slide. But it's very clear in experimental evidence that simply reading and rereading and simply sitting there by force of will saying, I will upload this information is an inefficient and ineffective method. And so if that is your process, throw out that highlighter and attend to these principles that will help you. This is an example of elaboration. this individual has constructed, and they've used some kind of design feature. You can imagine simply developing your own version of notes. You can imagine your own schemata. They have taken a content area, acquired new information from the lecture, from conference, from academic half day, from the podcast, from their reading, from the primary literature, from the review literature, and have built a representation that makes sense to them. At no point is there any highlighter here. They presumably have engaged with other material that they already know and have integrated that new information with old and have a revised elaborative schema. But even more powerful than elaboration is recall. Next slide. Now, I don't necessarily advocate for these archaic forms of actual physical paper flashcards, although this is a site where I'm a part of the editorial board for Canadian EM, which is a large educational free open access resource that if you haven't produced any flashcards in your own training, they're produced for you. Next slide. And certainly the digital world has thousands of variations or iterations of this. But the process of recall, not specifically flashcards, but the process of recall is even more powerful for learning than the process of elaboration in head-to-head studies. What happens there? It is forcing your working memory to access long-term memory and find the synapse, make its way through the network to find the node of information required. And it's effortful. As we practice routinely over and over, that work will increase the ability to access network and to find the appropriate synapse into that node and allows it to be brought into the working memory. Elaboration expands and increases the network so you have multiple roads to access that node. And simply reading and rereading with a highlighter just makes that one little highway more and more dense, but not as accessible with multiple different ways to get to the same destination. Next slide. And so if we want to be efficient and effective, then recall, mixed recall, effortful mixed recall may be our best option. So let me talk very briefly about this idea of desirable difficulty. I speak to my children frequently saying that when it hurts when you're doing your schoolwork, that's probably a nice little surrogate that you're being really profound in your learning. When it's easy, you're probably simply reinforcing knowledge and reinforcing skills and abilities that you already have acquired. Effort is one of those markers of engaging and really starting to learn, with the caveat that it needs to be desirable, that there is some point where your sympathetic system will turn on and you will not be able to respond. The bite is too big, the challenge is too large. And this idea of mix, and so the fancy word for mixed is interleaving. If you choose only to work on areas in one domain, I'm only going to address toxicology, then you build a network that's just really a subnetwork. But if you interleave toxicology, pediatrics, and cardiology, then you have a much richer network that's more representative of the authentic environment in which you're going to access this information. Next slide. So where have we come so far? We do not upload information, we construct it. We don't simply drag and drop. We require progressive sequenced feedback to ensure that the assumptions about how we are making decisions are actually leading to outcomes that are true, so that we can refine, direct course. And if we can sequence it, then the challenge of taking on a really daring or an audacious skill or ability or competence can be sequenced down into much more manageable pieces. We need a process that ensures that it's not a simple one-time intervention. And if we are believing that a single intervention will ensure stable long-term retention, then we're really probably fooling ourselves. We need to think about how we are spacing our learning. And then if we can use processes like elaboration and ideally like recall that are in a mixed practice, then we can be most efficient. And so the final idea around principles that I would encourage you to think about your own learning or how you might contribute to the educational systems you're a part of reflects a change in how we are structuring education. The current process for medical school and residency and certification and recertification really looks as the unit of analysis as the individual. And so we study on our own, we learn on our own, we write exams on our own, we demonstrate competence individually, and yet we turn to work and we practice in teams. We're social. Next slide. And as Bandura would assert, it's very clear that our social influences are profound in how we learn. Think of an opinion leader in your group who has influenced how you might want to learn or acquire new skills and abilities. I think of my own practice. I graduated before point of care ultrasound was a feature of training. And then as I saw members of my own business group using and routinely improving the quality of care in our department, this became something that I decided I need to acquire. And it was because I had a desire to imitate that I pursued this. Think of your role as a teacher. Most of the learning that your students acquire from you has very little to do with what you say, and more based on the modeling that your students have of how you act. What is the role of shared values and of pace settings? If you want to maintain your diet, simply put a wager with a friend who gets to collect on that money, and that psychological pressure will keep you much more in line with your plans for exercise and eat rightly, which I guess with all of us in a COVID lockup, we could all pay a little attention to. But equally, that same psychological pressure that comes from us as working as social beings within a group can be drivers to ensure that we are attentive to our own learning and no longer looking and reflecting at ourselves as simply the unit of learning as the individual, but being more attentive to the process of how we work and function as a group. Next slide. So I've talked about 5 principles. Before we go to Q&A, I'm going to just talk about 3 myths which really get under my skin and I want to debunk in some way. And I've been thinking about how we can play this game at home. You can't vote, and so I'm going to ask you to keep score for yourself. And if you tell yourself, put out 1 finger that's a true, be selective in which that 1 finger is going to be, and 2 fingers will be false. I'm going to say a statement, and then I'd like you to vote at home. Play along. Next slide. Learning styles are an important element that must be considered so that when you have students who are visual learners, they must be equally attended to students who are oral learners. So true or false? 1 finger for true, 2 fingers for false. Vote. This is definitely false. And I'm not sure if you played along, but I'll pretend because I can't really see you. The wealth of data is clear that learning styles are not a phenomenon. And so if you have students coming to you say, sorry, I need a partial task trainer in order to understand that, or I need you to create a whole podcast because I don't work well with the slide deck that you've shared. I think the simple answer is that's not something that needs to be accommodated. But neither should you use that as a reason to resist learning formats. And you should be cautious about the assumptions and the barriers you put before yourself unintentionally. Now, that's not to say that we don't align the instructional method with the goals of the learning. It'd be really ridiculous for me to write a textbook chapter on how to perform a technical skill. I should probably demonstrate that using a physical model, a phantom of some type. Equally, it would be ridiculous for individuals to simulate out developing a differential diagnosis for chest pain. It's resource intensive with little utility. So we want to not necessarily ascribe to this myth of learning styles, but at the same time be attuned, is the learning required in the best modality? All right, myth number 2. Next up. We're emergency physicians, so we want to believe this to be the case. You can effectively multitask as an expert, performing several tasks simultaneously. 1 is true, 2 is false. Vote. Let's see if you cheated yourself. The pattern here is becoming clear. This is definitely a myth. As much as we'd like to imagine that we can multitask, and as much as we know that we are interrupted, Carrie Chisholm's work on interruption is really profound. suggesting that we're interrupted every 8 minutes with a critical task. What in fact we cannot do is think in a very high intense or very conscious way about 2 tasks simultaneously. In fact, we do rapid task switching. We automate task 1 so that we can turn our conscious attention to task 2. Now, this becomes okay as we start to achieve mastery. We can pause and interpret an EKG while performing suturing of a patient because we can automate those technical skills once we've achieved mastery of that procedure. You should never ask the medical student to do that. Suddenly the fingers will be sewn together. But this assumption that we can multitask and that this is a function of our environment is a false recognition of how our brain works. And in multitasking, the big challenge is that we have degradation of information. When we automate task 1 to attend to task 2, we lose small amounts of the fidelity of that information presented to us as we transition from an automated to an attentive task. And so as much as we'd like to be able to provide pain and nausea orders for a patient and nurses talking to us while we're trying to manage a seizure in somebody who needs to be actively resuscitated, both patients are going to get less optimal care. The final myth, slide. And this is one that really strikes home. It's the idea that we can self-assess. It's the basis of our CME, our continuing professional development. So one, yes, we are effective self-assessors. We can be self-directed learners and set out our own learning goals. 2, we are ineffective. So vote. And so here we are at a hat trick. We are ineffective at self-assessment. We can't see what we don't know. It's hard to see your own lacune. The Dunning-Kruger effect would say that people who are high performers have the lowest assessment of their ability because they have a great perspective of the scope of the problem before them. Whereas novices have a high appreciation of their own ability because they are so new to the domain, they have no idea of the scope. So what does this mean for us as we continue to develop our own learning programs, as we try to maintain competence years and decades from training, as we want to ensure that we're providing the best care for our patients? It's not to fall into that fallacy of saying, I know exactly what I need, but it's to have others provide a peer consult to say, here's an area to be suggestive of. It's to get supporting or refuting data from your practice. And I don't mean the type of data that says 72 hours after you disposed someone from the emergency department, they got readmitted. That type of crude data is not helpful. But it is essential that we don't believe the fallacy of self-assessment. For myself, I stopped caring for children and moved to an adult-only emergency department for the most part about 7 years ago. When I left training, I thought I had competence to manage the pediatric patient who required resuscitation. Catch me on the wrong day, I probably would still believe that same assumption. I don't think I've changed. And yet what has happened? Over the last 7 years, I've had a dramatic reduction in the patients who are children requiring resuscitation. And as such, there's been a degradation of my skill. My own self-assessment would be impaired, but data from my practice or near peer support would suggest, hey, this might be an area that you should prioritize in your ongoing CME. Next slide. So I'm going to turn to Jim, and he's going to facilitate some conversations before we move to the final portion with some final thoughts.
Thank you, Dr. Sherbino. Let's take a few questions from the audience. In a few moments, we will answer questions from the audience. As a reminder for those who are attending the live session, please send your questions in via the Q&A pop-up window by clicking the Q&A button in your Zoom menu interface. We will try to get to as many questions as possible in our remaining time. So while the questions are coming in, I would like to ask Dr. Sherbino, what is the role for digital learning in the next generation medical education curricula?
So I think it's a pertinent question. In this era, we're seeing a massive transition of in-person learning being loaded online. I think there are some features that make online platforms really helpful. It speaks to scale. so we can reach and access a large population with very limited additional resources after the purchase of a platform or the use of a free platform. It allows asynchronicity, and so we don't require everyone to learn in step, and allows review so that you can access or re-attend to the information regularly on a tailored self-prescribed rate. And it also flattens a bit of the hierarchy of who is an expert teacher. And we've seen that as part of the free open access medical education movement, as people who were traditionally in universities or were identified as professors of emergency medicine or great teachers, they have been met alongside with other people who have a great wealth of experience, and now they have a channel and voice. But a caution. A platform is only a platform. If you developed online learning that did not think about the 5 principles that we've talked about, then you have a really lousy online process. Some people may be concerned about the utility, and so there's a great meta-analysis in JAMA. It's old, and here I'm going to do a shameless plug for my podcast, the Key Literature and Medical Education podcast, Keyline. You can find us wherever you get your podcasts. We recently did a review of this paper, and it essentially shows that compared to no other resource, online resources are really effective at teaching. And head-to-head with a traditional in-person, so an online resource versus a seminar or an in-person lecture, they have equivalence. And so nothing necessarily is lost. With the take-home caveat, if you don't have a principled approach to how you design your educational intervention, the internets are simply a platform and everything will fail.
Thank you very much. A question from Michael Brown. Does Bandura's social learning theory explain why the massive online open course, i.e. Coursera, excitement has now died down?
So what I think what you see with MOOCs is an attrition rate of around 95 to 97%. And what I think it happens is twofold. You feel disconnected and you may not have the same level of engagement. And second, you don't have that pace setting phenomenon of working with a cohort and moving through. I've been involved with a number of very successful online faculty development initiatives with a shout out to Academic Life and Emergency Medicine. And the secret there was not that we were online and we're effective. And certainly we spanned junior faculty and early career faculty from Canada, the US, and South America. So we had a large, diverse geographical set allowed by the platform. But the success of that program was that people worked in a cohort and engaged using the digital media rather than simply being isolated and anonymous looking at a screen. So I think, Mike, what you're suggesting is if you simply have a platform that does not allow people to engage and the social phenomenon is so powerful and so strong, then attrition is really high.
Thank you, very interesting. A question from Daniel Martin. Our ACGME requires that we have a certain number of residents present for our lectures to count for didactics. But since learners are always in different phases of knowledge, inoculation, and vaccination, then should most of our didactics be year-specific didactics for PGY1s, PGY2s, PGY3s, etc.?
I think it's Daniel. So thanks, Daniel, for that question. I'd turn you to the team-based learning literature. That's structured in an interesting phenomenon where you can sequence senior, intermediate, and junior learners within a team. And the process by which you engage in the material looks something very similar to the spiral models I've suggested, that you don't need to pull people apart to be effective, but in fact, you can have different tasks assigned to different levels of experience that allow individuals to participate more collectively as a group. And I think that's much more of a naturalistic social phenomenon. And be cautious too of assigning competence simply by postgraduate year. In Canada, we've made a transition to a competency-based model 2 years ago in emergency medicine. And while your pay still stays the same based on what calendar year you are in, you have the ability to advance forward or to have a delayed advancement in terms of the educational or expertise. And so whether you are junior, intermediate, or advanced. The calendar is not a good predictor about who is at the right level, and so be cautious of simply assigning expertise based on the PGY level, although it's a crude surrogate that works. Having said all that, I think models where we incorporate individuals together allow a senior to take perhaps an educational role or an explanatory role, where juniors get to be pace set by intermediates. That can be very powerful. And so no, I would not add to your complexity of conference by having multiple streams depending on which PGY level you have.
Very interesting. A question from Sarah Kleinschmidt. Any tips on how to implement these concepts you have discussed within current educational structures, like our isolated weekly conferences?
Thanks for the question, Sarah. It's a big piece. It would all depend on which tip and in which context. I'd turn your attention to the resources, and maybe if we can pull up the next slide, people can access that while we're talking. It will provide a number of different resources and a number of different examples, and then the reference list from this will allow you to go down whatever kind of rabbit hole that you're pursuing. I think we can be very effective at delivering education in this very unusual and novel time. I'm going to share an example from our own residency program. We have a very active simulation program. And so in the absence of being able to perform simulations in person, we are using some of the in situ simulations that we've conducted in our hospital in preparing and managing the treatment of COVID patients, and then have run simulations and debriefs in a virtual environment, being thoughtful about what's the process of debriefing informed by the debriefing literature, being thoughtful for the processes around the idea of practice and repetition essential for simulation, and thinking through these processes, but simply using a new platform to make sure it works. And it's been fairly successful, and we've published on that, so you can see some of that work coming up from McMaster.
Very interesting. We have a question from Joseph Reardon. Do you have a similar trend in Canada of mid-level providers developing special tracks? If so, how do we maintain the learning environment of our residency programs when we have multiple learners of quite different backgrounds in the learning space?
Thanks for your question, Joseph. We don't have the same proportional representation of mid-level providers in Canada, although we're seeing a trend that's showing it's a fairly steep curve as they start to come online. I would speak more broadly about the processes by which we see increasing specialization and subdivision in emergency medicine in particular, and in the House of Medicine in general. We should attend to the need to recognize sub and subspecialization, which I think is part of the question you're asking. Because that, if we don't attend to it, it's simply the process of sticking our head in the sand and saying science will not advance, and the task of gaining mastery of that area is not relevant. And I think that's a flaw for the delivery of best quality care for our patients. But at the same time, we should not take that as a way to denigrate the extreme value of generalists. And in emergency medicine in particular, I think we have a really interesting role to serve in educational and administrative and in clinical practice within medicine in general, because as generalists, we understand the integration of all of the different specialties and subspecialties and subspecialties within medicine. We see that intersection. And so your question about how do we challenge streams that would look to only providing training in a very narrow area and having multiple streams at intersection or at heads with a more generalist approach. I think the process is to ground as the organizing feature generalist training to ensure that the breadth of emergency medicine is captured, and for mid-levels who are participating in emergency medicine practice to have contact there. To allow moments within some organized curricula for people to follow specific streams and gain experience, but always with the goal of linking it back to how does it integrate more broadly. There's nothing I find more frustrating when I consult an ophthalmologist for a retinal detachment only to be told they're an oculoplastic physician and they don't really know what to do. It's important in my practice to have an understanding of how this is going to be managed in the time frame for such. But it's also important for patient care that we have an integration. And so I would suggest that an education system should ground it in the general process, and we should continue to endorse and support generalism, which I think is a key element in the delivery of medicine. We should allow moments for people to achieve subspecialization, but not in absence and not in allowing them not to attend to their commitment to the generalist practice that is their starting point.
Thank you very much. We have a question from Stephen Polvoy. What do you see as the future of CME, given the principles you have described in this presentation?
I'm going to turn to the work of Lara Cook, who's at the University of Calgary. And so I'm going to reference her because I'm going to steal her big idea. She's written about this in the Implementation Science Journal. The current model in Canada is I am maintaining my certification if I subscribe to a bunch of journals and I go to a bunch of conferences. And most of those journals, well, they're not print anymore, but they sit somewhere on my iPad, sometimes read, most often not. And at most conferences, I'm more interested in seeing my friends and maybe on occasion presenting one of my posters. I think that model is really flawed, and as much work as we've seen done at the graduate medical education, the next big challenge for us as educators is to tackle continuing professional development. What Lara would suggest is that if we situate our continuing professional education in a socialized group form, we can see better outcomes. And so she's done this experimentally with a collection of physicians, in this case, neurologists, who received very discrete data points about their common practice in a single city, addressing a topic that they all thought was important. So they identified the topic. The EMR provided very specific, detailed patient outcomes that were provided to each individual to show how care was being provided. And she almost describes a Kubler-Ross type of phenomenon where at first there was anger and denial, and then sadness, and eventually reconciliation, as people made various excuses as to why that data didn't really reflect their true practice. And when in fact, the homogeny across academic neurologists in a single center, they're pretty common. But then collectively, armed with that individual knowledge, they then were able to work out, here is the solution to the gap that we've identified. We have a problem, we understand our data as to where we are, and now let's collectively work on that. In the pace setting, the inter-accountability ensured that that group of neurologists were able to tack off a real world problem that would have real world implications to their patients, and then develop it in a way that was not ad hoc, but that actually led to a step forward in that entire community. I think that's really interesting. It requires feedback, it demonstrates social accountability, and it leads to the identification of a problem that people don't just imagine, but is informed by the data there.
That's very interesting. We have a question from Dr. David Sklar. Many academic physicians, either as clinician scientists or administrators, begin to spend less time clinically, and their expertise potentially deteriorates. Yet it is important that they maintain clinical involvement. How do we suggest that they address the inevitable loss of clinical expertise through continued learning?
Thanks, David, for your question, and I hope that you're enjoying your time post-academic medicine. So it gets back to the idea of expertise, if unaccessed, will show decay. Now, where that shows decay will be probably individualized to the practitioner, and also must be balanced with changes in implementation of new sciences and new approach. And so there's a fundamental element of decay, and there's also an element of non-acquisition of new information. I think the process is, one, attention, and simply asking that question, I think, is the most important first step. I'm not convinced that our current processes ensure that that all of our senior physicians are thinking about that. And I'm starting to get into that realm where I need to be a little bit more careful what I say, because I have some junior colleagues that are far brighter, far better, and better teachers in many ways. I think the second part is we need to not go from an abrupt 0 to 100 and then 100 to 0 in terms of our rate of practice. One of the things that I think is very interesting and very important for us in medicine, unlike all of the other professions, is that our senior leaders and our educators are still in active practice, and we accommodate that. If you go to a law school, if you go to a nursing school, if you go to an engineering school, none of the professors of engineering, nursing, or law will actually be in practice. And they will speak without an authentic accuracy about how things work. And so I think it's important for those of us who find ourselves in clinician scientist role not to divorce our clinical practice. It really informs our practice, our science. And for those of us who are in administrative roles, not to completely divorce that. It informs our administration, et cetera. And then the third role, I think, is the role of simulation and the role of coaching. Simulation for obvious reasons, the acquisition of new skills. Coaching, I think, can be very profound. Atul Gawande wrote a really important piece in the New Yorker that sparked this whole coaching model. Most interestingly, in Wisconsin, they have a surgical coaching model where cases, particularly bariatric cases, are filmed, and then a peer coach will review those cases and provide tips to improve performance. And much like Atul Gawande suggested, it was 3 hours doing a routine thyroidectomy with a surgical mentor that transformed his practice rather than hours of reading the journals and or going to conference. So I think there is a role for us to think about near peer coaches for clinicians who are increasing practice or who want to maintain practice after they've been divested to these other academic roles.
Yes, sounds very good. One final question from Nabila Mayat. Looking back on your own journey of mastery and when you were a medical student, is there anything you would have changed when you think of the learning revision methods you used to use? If you had to choose a top tip for the medical students out there now, what would it be?
Oh, you're asking me like to choose which of my 3 children I love the most. That's a hard one. I think a really important piece is to understand that you need to be systematic. And maybe that's the thread that comes through all of the 5 key principles that I've wanted to share. If you just jump in, the excitement and the enthusiasm of learning and of engaging in a lifelong passion is really generative. But at some point, the volume and the scope and the scale will catch up and the imposter syndrome will rise to the top. And I'm not sure if this is an antidote to the imposter syndrome, but I do think being systematic and planning it out in the same way that you might plan out other elements of your life. With a plan, you can see moments where you can find efficiencies and moments where there's redundancy. And being systematic and saying, I want to spend, before I dive into the deep end, a little bit of time mapping out the scale and the scope of what the pool looks like. So I know where the ladder is, I know where the lifeguard sits, and I know where the shallow end is in those eventualities that I need it so that I can achieve whatever I'm planning to learn here during this swimming lesson. The metaphor kind of breaks down a little bit. But in the absence of systematic processes, we end up with educational systems and educational practices that we've done all our life. Because as a medical student, you've already been through undergrad, perhaps through grad school, certainly you've been through primary and secondary school, and you will just continue on with the practices that you always did, highlighters and all. Well, probably guessing your generation, you have no idea what a highlighter is, but if you have that highlighting tab in your PDFs, that's just as bad. So systematic, laying out the landscape before you begin, I think would be the most helpful meta principle to adopt.
Sounds great. Thank you again to Dr. Sherbino for sharing your expertise. Do you have any final remarks?
I do. I want to have everyone work through a very brief exercise. This is the moment on your phone or on your computer. I want you to send yourself an email. And I want you to keep this email in your inbox and don't erase it or move it until Sunday morning. And I want you to answer this question that you see here on the screen. This is my weak attempt to undo the irony of a single intervention to change your knowledge and to change your exposure to education theory. So what is it? What do you want to research, and who do you need to talk to, and what do you want to start doing? As you think about it, I'll just tell you the funny story. For me, I'd given, not this talk, a variation on some education theory, and I realized at the end that I was a hypocrite. I wasn't doing some of the things I wanted to do. And so as a result of that initial talk I gave, I reached out to our senior residents and said, give me your electronic flashcard deck. And I uploaded and I started the practice of reviewing material that I knew cold 15, 20 years ago. And it was effortful, let me tell you. And I did not want to interleave it. But I know that it was a helpful reminder, because the things I thought I knew cold, my self-assessment was not on target. Next slide. And so these are the principles, they're not the processes. You need to figure out how to implement them. You need to figure out how to tailor them for your context. You know what you need, you know what your education program needs. These are not exhaustive, and the resources will provide further details. But if you can think of these 5 principles, I think you can take that magical 10,000 hours, that interminable period of residency and undergrad training, and perhaps find moments of efficiency, so that's not simply being stuck there until the bell rings, but where are the moments of effectiveness? And so here's what we need to recall. We construct knowledge. We don't simply upload it. The wicked problems of emergency medicine require specific staged progressive feedback. To sustain learning, you don't need a single vaccination, you need multiple re-inoculations. Effortful, mixed recall of knowledge is best. Elaboration is great. Simple forced staring at a resource is inefficient and ineffective. And finally, we learn by observation, by watching others, particularly others who influence us. Our students learn by watching what we do and trying those actions out. We learn by finding ourselves in groups with shared values. And so with that, many thanks to SAEM for this opportunity.
Wonderful. That was outstanding. Well, thanks. That concludes the keynote address for today. In a few moments, we will begin our next session. Thank you very much, Dr. Sherbino. And now we are going to jump right into our next presentation on COVID therapeutics. For those of you who are just joining us, I am Dr. Jim Holmes, president of SAEM. SAEM is the premier international organization representing researchers and educators in emergency medicine. In our work, SAEM promotes and facilitates scientific discovery, educational innovation, and professional and leadership development of our members. Today, we are proud to bring you a COVID-19 presentation entitled COVID Therapeutics. During this presentation and during our question and answer session, you will hear from Dr. Paul Auwaerter, the Sherilyn and Ken Fisher Professor of Medicine at the Johns Hopkins University School of Medicine and the Clinical Director for the Division of Infectious Diseases and Director of the Sherilyn and Ken Fisher Center for Environmental Infectious Diseases. Dr. Auwaerter will share his experiences fighting the COVID-19 pandemic, providing along the way guidance and insight that will likely prove invaluable to the rest of us as we care for our patients in our own emergency departments and communities. During the presentation, you may submit questions for the presenters by clicking the Q&A button in your Zoom menu interface. Questions that are upvoted will be prioritized during our question and answer session to start immediately after our presenter has concluded. We also want to recognize several experts that are joining us online behind the scenes and will be helping to answer questions throughout the presentation, including Dr. Andrew Meltzer, Dr. Ryan Lafayette, Dr. Namita Jayaprakash, Dr. Colin Grenadier. Thank you all for your time and expertise. It is greatly appreciated. To begin, I'd like to introduce Dr. Rich Rothman, SAEM's COVID-19 Planning Chair, to provide the opening remarks for today's presentation. Dr. Rothman is the Executive Vice Chair in the Department of Emergency Medicine and Professor of Emergency Medicine at Johns Hopkins Medicine. His research program focuses on the interface of emergency episodic care and infectious disease surveillance, diagnostics, and treatment with research on varied commonly occurring ED conditions, including pneumonia, skin and soft tissue infections, sepsis, HIV, STDs, influenza, and now COVID. He has particular expertise in development, translation of rapid and novel molecular diagnostics. At Johns Hopkins, he works with an interdisciplinary research team, including investigators from emergency medicine, microbiology, infectious disease, and public health. Currently, Dr. Rothman serves as principal investigator for the NIH-NIAID Center for Excellence for Influenza Surveillance and Research, as well as a lead on a BARDA Health and Human Subjects Cooperative Agreement to study new approaches to advance therapeutic trials for pandemic response. Dr. Rothman is also one of the founding members of the SAEM20 group, a national network of academic emergency departments focused on research practice and policy on emerging and transmissible infectious diseases. Welcome to you, and thank you for being here, Dr. Rothman.
Thank you, Dr. Holmes, and thank you to SAEM for hosting today's COVID session. Soon you'll hear from Dr. Paul Auwaerter, who, as Dr. Holmes mentioned, is a professor of medicine at Johns Hopkins University School of Medicine, as well as clinical director for the Division of Infectious Disease and director for the Sherilyn and Ken Fisher Center for Environmental Infectious Disease. I've had the pleasure of working with Dr. Auwaerter for nearly 3 decades as a colleague at Johns Hopkins. Dr. Auwaerter serves as the executive director of the Johns Hopkins Point of Care Information Technology Center, which produces numerous guides on antibiotics, HIV, psychiatry, and diabetes. Dr. Auwaerter also serves as editor-in-chief of the antibiotic guide that over the last 20 years has grown to be a standard reference for infectious disease-related clinical decision support and rational antimicrobial management. His research and clinical interests include improving diagnosis and care for patients with Lyme disease and other tick-borne infections, as well as surgical infections, Epstein-Barr virus, respiratory diseases, and antibiotic resistance. Dr. Auwaerter is past president of the Infectious Disease Society of America, the largest professional society worldwide related to infectious diseases. Probably nowhere in the history of medicine has there been such a rapid rush to design, develop, test, and evaluate the impact of varied new therapeutics in such a short period of time. Dr. Auwaerter has been leading some of the efforts at Johns Hopkins to evaluate and assess new therapeutic trials. His extensive history as a researcher and national leader in therapeutic trials for infectious diseases gives him the perspective to help us understand this rapidly moving field as we consider current and future therapeutic options on the horizon for patients with COVID. Welcome, Dr. Auwaerter, and thank you for taking the time to prepare these comments.
Thank you so much, Dr. Rothman, and also to Dr. Holmes and your society for the invitation and speaking today. The topic is COVID therapeutics, and I think as many of you know, we are learning so much about this particular RNA virus that we are in its infancy, but really perhaps even at very first steps in terms of therapeutics. But I think I'll try to give you a glimpse as to where we are and what at least over the next few weeks might transpire. But as always, this is such a fast moving field. Thankfully, there'll be many more efforts and so on. So next slide, please. This is my disclosure, long time stockholder since my aunt suggested this years ago. Next slide. You know, when it started off, I have to say, when this appeared on the scene, many of our clinicians at our hospital were faced with an issue, and that is, okay, there's very little data, but we want to do something for our patients, something more than just supportive care. What can we do? On the other hand, there were people that had advocated, well, we don't know what works really in the way of clinical equipoise. The only rational way we can offer treatment to patients is through a clinical trial. And certainly that's a very valid point of view, except many hospitals, including our own, did not have clinical trials operating. And of course, many smaller hospitals do not have this opportunity. So it was that kind of tension that I think was really fraught and led to lots of conversations and really different points of view as clinicians, whether you would try something for which you are extrapolating from small amounts of evidence, or would you just wait, do the best you can, and wait until there's a clinical trial or better information. And of course, there's arguments on both sides of this, but this was indeed a tension that still continues to this day, just based on the fact that we have so little information and patients are so desperately ill. Next slide. So just quickly, many of you are already familiar with COVID-19, which is a disease name from the SARS coronavirus 2, which is the pathogen. And initially, there's a very robust viremia, even in people that are asymptomatic, but then that tails off. And not everyone, but many patients, 5–10% or more, higher in other risk groups, seem to have not an abnormal, but a heightened immune response. I mean, the immune system quite goes berserk. There's a cytokine storm, which has been popularized and can cause tremendous injury to organs. And of course, the lung had gotten the most press with ARDS before recovery. So there have been many ways that this has been proposed and tackled with the idea that antivirals might work best early on, that if people evolve into severe COVID and the hyperinflammatory response, approaches that quell the immune system are thought to be the way to go there. But of course, we are really only still learning about the impacts of this virus. And, you know, having grown up in New York City, in terms of being a medical student there during the HIV era, in a way, once we sort of identified the virus and knew that it tackled the CD4 cells, it made sense why people developed opportunistic infections. Here, this is a much more confusing virus, I would say, at this stage. So we still have lots to learn. Next slide. Now, all of you think of a number. How many drug intervention trials are there now for COVID-19? Dr. Rothman, you get your number ready. And if anyone guesses it, they win all the jelly beans. Okay. This was just, and this may be wrong because I looked just 2 hours ago. Ready? Advance. 558 drug trials. These aren't all COVID trials. These are just the drug intervention trials. So obviously a stupendous number. Some of these are very well designed trials, others are not, but this is the registry, and that includes the WHO and so on. Next slide. So I think patients and even some clinicians forget this is a viral disease. You don't kill a virus. The virus needs to co-opt a host cell in order to replicate. And if you use influenza as a model, and I know in emergency medicine, many departments have now pivoted to providing antivirals for influenza at early stages, because we know the earlier you administer that drug, the better you are, with the idea that if you can prevent the virus from infecting more cells, you probably will decrease the viral load and the host cell damage or host immune responses that cause injury. Now, whether this works exactly the same in this coronavirus is unclear, but there are a number of interventions, and straightforwardly, I think most people can grasp that antibodies or convalescent plasma, if circulating, would block the coronavirus from docking with the ACE2 receptor, which is the key receptor. I think many people don't realize, though, that this is not sole and sufficient for viral entry. There's a serine protease, TMPRSS2, such a catchy name, that's required for the virus to enter. And there have been strategies with drugs such as Camostat to block that. Now, this is a serine protease inhibitor. It's actually it's approved in Japan for chronic pancreatitis. So it's already been trialed in humans, so it is in randomized controlled trials now, but this is sort of at the viral entry phase. The antimalarials have been targeted as perhaps interfering with acidification and the phagolysosome, which is part of the endocytosis of the virus, and therefore interfering with further viral replication. Protease inhibitors used for HIV have been used very commonly in Asian countries pretty early in January. And we're often part of the routine administration, although a clinical trial, RCT, really showed that this drug failed. It has a very high inhibitory quotient that won't be reached with customary dosing of this compound. Remdesivir we'll spend some time on, is a nucleoside analog, much like AZT was for HIV, which really gums up the RNA replication and protein translation process. Next slide. Now, you've heard of so many drugs. I mean, it's sort of like your Aunt Zelda he said, I just heard about this drug that's going to work against the coronavirus and be a cure. There are scores and scores of these. And in fact, some of these are based on some reasonable in vitro studies that show that if you put a drug into a cell culture with the virus, that you produce less virus. The problem with many of these in vitro studies are many of these agents sicken the host cells. So if the cell culture itself isn't as healthy, of course, you're going to diminish making new virus. And the issue there is anything that looks good in the test tube has a super high failure rate once you put it into human trials, because this is a far different process. And the landscape is littered with agents that were thought to work against Ebola or influenza in the laboratory, but yet have not translated in clinical practice. So The menu is very large for study, but probably the candidates that will work will be few. Next slide. So much of what physicians pivoted to here in North America were shaped by the Chinese guidelines in February of 2020, which had this menu here. Some of the drugs we've already talked about, but included anti-influenza drugs, in part because they didn't know if they were fighting flu or the coronavirus, an immunomodulator, which we'll talk about, tocilizumab, and also traditional Chinese medicine. In fact, many of the trials from China, you'll look at the treatments included 3 or 4 of these, often in combination. And so this was all, again, either decisions based on in vitro data or case series. And much of this was adopted by others when we didn't have more information. Next slide. So let's go down the antivirals for a moment. Next slide. I think rightly to start off with remdesivir. This has been in the news, of course, for many reasons as an antiviral. It's only available intravenously as a prodrug and needs to be metabolized to a molecule that serves as a nucleoside analog. And much like any of those medicines that interfere with RNA, replication will inhibit that and therefore pretty much staunch further production of subgenomic transcripts that can then be made into proteins. So a very effective strategy. And typically we think, much like with influenza, antivirals have to be given as early as possible to have maximal benefit. And what's a little different with the coronavirus, of course, is people often aren't presenting perhaps as early with their illness as influenza. Some of that could be education, but really the virus actually proceeds a little bit more slowly than influenza, which can hit you as a ton of bricks within hours and sort of wake people up to call the doctor, whereas this is a bit more insidious and often has already been replicating for a while before producing symptoms. Next slide. So already it might be a bit handicapped. However, this trial got a fair amount of press. It's not really a trial. It's a report of compassionate use of the drug in Gilead for severe COVID-19. And it was 61 patients. And people found it quite remarkable because they said, well, look, 70% of these people needed mechanical ventilation, yet nearly the same 70% had improved with receiving the drug, and 13% died. And so the question was, well, doesn't this look very favorable? And the problem is, of course, there's no placebo arm here. And I think if anyone knows otherwise, I think it's the only time a compassionate use series has been published in the New England Journal. But people were very hungry for information, and it's important to point out the side effects of this drug include liver function test abnormalities, as well as the fact that there are warnings that it has a carrier as an intravenous drug similar to voriconazole that can accumulate in renal failure. So GFR under 30, the drug is not supposed to be used, but we use the antifungal drug, for example, all the time in these settings. So I don't think that would necessarily staunch the prescription of this if you had availability. But this was some of the preliminary information, so people had their hopes up. Next slide. Well, and then later in April, just a couple of weeks ago, this randomized trial from China came out in the Lancet with 237 patients. And this was in the news. You may have heard that it was halted early, in part because they had trouble recruiting people because they were often treated with other drugs or they didn't wish to enroll. And also they didn't see that there'd be much meaningful improvement in terms of their primary findings. So there is no clinical improvement, there is no mortality, and perhaps most disheartening, there is absolutely no impact on the viral load. That is, this drug, which is supposed to inhibit the virus, didn't seem to have any effect in either upper or lower tracts. And this coronavirus does have a predilection for the lower tract, replicating more, probably because there's more ACE2 receptors in the lung compared to the upper airways. There was a subgroup trend, as you can see here, that if patients had gotten the drug earlier, that there was some trends towards improvement, but this did not look very helpful, or at least I should say, obviously didn't have a dramatic effect on outcomes. And this same thing, this is the same argument you've been hearing about oseltamivir, right? I mean, for years, how effective is it? And, you need to give it so early. Does it really have much use after day 3 or 4 of illness, and so on and so forth? Next slide. Now, the trial that clearly has changed behavior is this ACT trial, which is adaptive, NIH-sponsored trial that began in February and is multi-site with the bulk of the institutions in the United States. And we only know press release data yet. This is it. Apparently, there'll be more analysis and publication of results, but this is what we know. That patients were said to respond faster with time to recovery receiving remdesivir versus placebo. And this was statistically significant. Interestingly, this trial in late March changed its endpoint from an 8-point composite score to this length of stay or time to recovery score. So some people have questioned why that was done, although it's been said that even with the composite score, it would have reached statistical significance. We'll wait and see what the data shows. There was not survival benefits. This is what press had said, but honestly, you have here, maybe 92% confidence in this, that there was a mortality benefit, albeit small. How many people might you need to treat here? 26 to 28 people are needed to be treated to prevent death. And was this drug being given as fast as possible? So there are additional Gilead trials that are being sponsored that will certainly add to this. And this trial, next slide, is an adaptive trial. So it is concluded, actually, the DSMB did not do an interim analysis. They actually they enrolled so quickly, they got to the final enrollment and then they analyzed. But regardless, the trial is now adapting and is moving on because remdesivir is thought to be the standard of care, at least from a investigatory standpoint. And so instead of a placebo arm, remdesivir will be the control arm. And now a drug called baricitinib, which is a JAK1, JAK2 inhibitor, which interferes with signal transduction and protein expression within immunomodulator cells so that there's blunted immune responses, will be how this trial will proceed. Next slide. I think many questions have arisen because as this drug received FDA emergency use authorization, this is not FDA approval, of course. It's still an investigational drug. But Gilead had said it would donate 1.5 million doses. Looks like the reality would be more like 750,000 doses. And the initial rollout was very confusing. For example, our 5-hospital health system got a total of 10 vials to one of the hospitals, Sibley in DC, and that's enough to treat 2 patients, for example. So there was, and other centers got none, some got a lot, and no one really understood it very well. There was a lot of criticism. Advance, please. So as of a couple days ago, there was a change from the US government that it will now be shipping to state health departments for allocation. But I think there's still questions as to how much will be available and received. Estimates are that there might be enough to treat 76,000 patients or so, but there's both a 5 and a 10-day regimen. Some institutions are thinking of only giving it for 5 days to extend supply. Next slide. Moving on, another antiviral is something from the old hepatitis C playbook. Remember when we made patients very ill, giving them interferon and ribavirin? So the strategy here was the same in this trial from Hong Kong that was published recently in the Lancet that used interferon beta in combination with a protease inhibitor and ribavirin, with the control arm being just the protease inhibitor. And you can see there the endpoints were simply as a phase 2 trial, time to nasopharyngeal swab negativity. Next slide. The findings here on a 2-to-1 randomization protocol were that enrollment was by 5 days as a median, but interesting findings. The viral carriage was reduced by 5 days. You can see here 7 versus 12 days average there, with a fairly robust p-value and confidence intervals, though somewhat wide. And faster alleviation of symptoms with a 4-day improvement. So you're tracking something close to remdesivir here. And what they used was something called NEWS2 as sort of a clinical amalgam of symptoms, but that's how they rated this and determined that those in the combination group. Adverse effects, as you might imagine, were nausea, diarrhea. They said there was no difference, which is hard to believe with interferon. And there was not a true placebo arm. I think many here are whether this can proceed, it needs a larger trial, of course, but one of the key difficulties with therapeutics are we don't know who's going to proceed to severe COVID. We might have some ideas like the very elderly, for example, those with comorbidities and so on, perhaps patients with obesity and some of the other groups that seem to be hospitalized at higher frequencies, dying more. But on an individual basis, we really don't know. So the question is, are you going to give a drug when people are feeling crummy that's going to make them feel much more crummy? And yet we still aren't sure if there'll be endpoints avoided, such as mechanical ventilation, mortality, and so on. So I think this remains a reserve, but is potentially promising, and I'm sure this will also be studied in combination. Next slide. The antimalarials. Yes, hydroxychloroquine and chloroquine, I would say, still being used in many hospitals. Others have stepped away. The long and the short of it is that there is not yet any compelling reason to use it or not use it. I'm not going to go through all these trials. Many of them were early on that influenced people, mainly from the French studies by Gautret, that suggested there was a much more potent decrease in viral shedding with the use of hydroxychloroquine, and especially if combined with azithromycin. The two studies at the bottom pointed to toxicities, the Molina and the Borba, whether using these drugs, which gave people some pause. Next slide. This study was published in JAMA earlier this week and was mainly the New York State experience in 25 hospitals, a retrospective series. Again, this is the kind of data that just makes you stop for a moment, because I was told back in my younger days that you would never really want to make treatment conclusions based on retrospective data unless if you had massive numbers. Here you have, though, 1,400 plus patients. It is, I think, the largest trial experience that's reported. It's not really a trial, it's just a study experience. And what you can see here is that both hydroxychloroquine and the combination with azithromycin scored higher on mortality. And again, another cause for pause. There certainly was not a trend or evidence of benefit. The azithromycin, the the neither drug arm and the hydroxychloroquine arm on this graph are superimposed, so it's hard to tell that there's actually 4 lines. But I think this is the kind of information that, if anything, just gives people pause about giving it, especially in patients that are more ill. Our critical care specialists have elected early on not to use it in any of their patients coming up to the intensive care units because of cardiotoxicities. And although many people had prescribed it or in combination early on, I think those numbers have decreased. Although the drug's still being used, we still don't really have quality information regarding it. Next slide. And the safety concerns have been growing. The French have always had a pharmacovigilance study and going across their entire country. And for example, in March, 43 of their 53 cardiac issues were traced to either hydroxychloroquine or the combination with azithromycin. And then the VA study, again, retrospective, got a lot of press because it looked like those that received hydroxychloroquine or the drug with azithromycin were more prone to die, including after when they were on ventilation. Of course, all the caveats go with retrospective analyses, because maybe the more ill patients initially were given this drug, when perhaps if they're suggested to you be effective as antivirals, they should only, if they do work, it may be best in the modestly ill. Next slide. So a meta-analysis that was released earlier this week looked at the available studies that passed at least some muster for a meta-analysis, and basically found that there was really no information yet that it could endorse or refute use of these antimalarials. The same conclusions have been reached by the NIH and the Infectious Diseases Society of America, that there's not good information one way or another. But I do think the toxicities are causing people to give some pause. I will mention that there are federally sponsored NIH trials afoot for both using hydroxychloroquine or the combination with azithromycin for treatment in hospital, also for treatment in outpatients, hydroxychloroquine, and there's also a prophylaxis study which is being run out of University of Minnesota. So we should have some quality data on this combination moving ahead in the next, hopefully, summer or fall months. Next slide. So moving into illness and people with severe COVID, which could certainly have reduced oxygenation on the basis of only the viral effects, it's really the hyperinflammatory effects that seem to cause the most grave damage and get people on mechanical ventilation or even ECMO. And these are characteristic by intense inflammation. We see very elevated levels of inflammatory molecules generated, such as ferritin, C-reactive protein. There are elevated D-dimer, and then interleukin-6 is elevated, not as high as might be seen in conditions such as CAR T-cell cytokine release syndrome. Probably an IL-6 level of 80 appears in at least 2 papers to correlate with severe COVID disease, which I think other studies hopefully will look at. There's still no one clear discriminator or combination for predictors, but this is sort of the landscape. And then, although the lungs got all the initial press because it is a respiratory illness, it's clear that when you're in this severe COVID phase, that all organs can be affected. Next slide. And the lung, though, got the highlight, and many of you are familiar, of course, with ARDS. This isn't usually a common presentation in the emergency department, but rather evolves after presentation. But characteristically, you know, with bacterial sepsis and others, this is a disorder of activated neutrophils and tissue injury and so on and so forth. But this is not this kind of heterogeneous disorder, at least this sort of common understanding is not how this coronavirus causes ARDS. Next slide. Rather, it seems to be following the influenza playbook. And the influenza playbook is that a small number of patients do develop ARDS, even as the viral carriage decreases with intense inflammation, elevated IL-6, and appears to be a disorder of T regulatory cells that just, again, cause this intense cytokine release and inflammatory syndrome and subsequent tissue injury. And of course, once tissues have been injured sufficiently for a period of time, it's not clear that anti-inflammatory mediators are going to be effective. Next slide. One that's been gathering a lot of press is the fact that this virus appears very commonly to cause clots. And it's not exactly clear why, but the coronavirus clearly docks to the receptor on endothelial cells, which of course do line blood vessels. And there's elevated D dimers, other factors here, as well as something that seems in some patients to mimic TTP with an acquired Adams 13 deficiency, or even elevations in lupus anticoagulant. These seem to at least be the current characterizations. Next slide. And here's just some selected papers showing very high rates of clots, such that many, especially in the ICUs, are going to high intensity anticoagulation. And I think there'll be even more papers showing, if we look, you'll find more clots that aren't yet clinically identified in patients once they're in hospital. The one that struck me, I think, especially was the Italian study, which was large, but look, that 50% of the clots were identified in the first 24 hours. So this can be a very early phase, although of course Italy had, I think, one of the more severe the population is more prone to severe COVID disease. Next slide. So moving to plasma and immunotherapies in closing here. Next slide. This has been proposed as treatment based on a lot of history where these treatments do work against a variety of viruses that you see here. Next slide. And was trialed in the original SARS epidemic here. And although not a very large study, as you can see, advance, please. Those that got the plasma treatment on the early side, and for example, before they had antibody development, but yet still had positive viral carriage, fared better in this analysis. Next slide. So this has been proposed. In fact, in late March, the FDA authorized an emergency IND. Although the FDA was not supplying the plasma, it was up to the clinician to find it. The trials at the moment include both early treatment, including in outpatients, which is actually being spearheaded here at Johns Hopkins, but is multi-center. Treatment of hospitalized patients, including the ICU, which is part of this expanded access, but the Mayo Clinic is accumulating data as a coordinating center for those that wish to input data, as well as prevention. Next slide. Now, everyone thinks, oh, well, this is direct neutralization of virus, but especially with those that are getting the plasma later on, there's been issues whether, for example, it merely is working like IVIG in this later phases where viral titers tend to already be declining, or doing some sort of other immunomodulation and impacting the hypercoagulable state. Next slide. So there's very scant data to date. Here's 3 small series that say everybody improved. I don't think anyone publishes bad results early on, but these are the 3. And it all looks like, gosh, this is what this is duck soup. This should work. but let's wait for the trials. I would say this is still an investigational approach. Next slide. And here are the risks. I don't think we'll necessarily start infusions in the ED, but maybe at some point in the future, or study enrollment. But there are all these risks, although some are very small, such as TRALI. And of course, patients in heart failure can have volume overload. The others, I think you're all familiar with any blood product administration. Next slide. Now, the immunomodulators, anti-IL-6 therapies have gotten a lot of press. One was sort of shut down because there were negative outcomes in the severe COVID disease, but actually looked like it helped in patients in the critical group in the ICU. So this drug trial adapted and was changed. So we're still waiting for further data and results. Next slide. Tocilizumab, which is an IL-6 receptor blocker, has gotten a lot of press and use, actually, although it's, of course, quite expensive. It was approved for conditions like rheumatoid arthritis. Blocking IL-6 and subsequent signal transduction to foster additional inflammation. Next slide. And it's these kind of testimonials that I think have given it some popularity based on anecdotal evidence. This is a colleague from Hong Kong, where you can see 1 day after administration, this patient markedly improved. And it's hard to imagine that this viral disease would really improve on a dime spontaneously. And this is other Lazarus-like situations in critically ill patients has also been seen and discussed regarding convalescent plasma. But I think we'll just have to wait for larger trials to really understand its worth. Next slide. One hopeful sign was this French study that said, oh, this drug does improve outcomes and with moderate or severe COVID disease. So this seemed very hopeful, but then there's been silence. And in fact, a colleague of mine who lives in Paris pointed out in the French papers this, which he translated from the French. Next slide, or advance. According to the French press, in this study, the entire DSMB, the Drug Safety Monitoring Board, resigned. So, you know, I think with the rush to publication and so on, I think we all have to be very cautious interpreting results and trying to do what we can to see if they can be trustworthy. Next slide. Now, the NIH has published guidelines. This is sort of the what I would say they're extensive. They deal with pregnancy and others. These are just in the interest of time. I thought I would just highlight, much like the EUA for remdesivir, it's only for severe disease. You do have to have lower oxygen readings on room air or be on supplemental oxygen, mechanical ventilation, or ECMO. The antimalarials currently are only recommended in context of a clinical trial, and based on the Borba study, they recommend against high-dose chloroquine, which is a quite limited supply in this country, actually. IVIG, and this is not the convalescent plasma, but just straightforward immunogammaglobulin, has been recommended only in a clinical trial and insufficient data for using IL-6 inhibitors. Next slide. And of course, those guidelines are going to be updated regularly. And as I mentioned, all of this hopefully will be improved in terms of its amount of data and how we can help guide patients. But I think there's already a palpable sense that, you know, early on in a rush to do something, we hope we didn't harm our patients. And I think that remains a very clear consideration, that we do not wish to do that. And all these therapies have that potential. There are numerous trials afoot. Remdesivir, I think, does have promise as an early agent. I'm hoping that there'll be oral nucleoside analogs that might work. Some of those are under study. And of course, the earlier you use it, I think vaccines are in the distance. And so we're looking for therapies, not only plasma, but even some monoclonal antibodies that I think hold some promise. And in terms of immunomodulators, I think people giving it latent disease after the tissue injury. The horse is out of the barn. So it probably is best given earlier, but we still await studies to really refine this information. Next slide. Oh, back one slide. Rich, that's everything. And this is by no means comprehensive, but hopefully was helpful with some of the highlights.
Thank you very much, Dr. Auwaerter, for this timely and insightful presentation. In a few moments, we will answer questions from the audience. As a reminder, for those who are attending the live session, please send your questions in via the Q&A pop-up window by clicking the Q&A button in your Zoom menu interface. We will try to get it to as many questions as possible in our remaining time. So while the questions are coming in, I would like to ask, what, in your opinion, is the most promising therapeutic modality that we know of right now for COVID-19?
Yeah, the crystal ball.
Yes.
Yeah, the crystal ball, my crystal ball is probably going to be wrong. But clearly, I think nucleoside analogs have a role if taken early, I think, in all likelihood, if it's safe. But otherwise, I have a feeling it's going to be monoclonal antibodies that might be able to be generated in sufficient numbers, in addition to convalescent plasma, if the early trials do show promise there, that I think will give some hope, because I think as we loosen social distancing restrictions, the fact that we don't yet really know that we have great treatment makes everyone very nervous, and we don't have a prevention yet strategy. So those are the two that I think, although there are, other candidates as well, but based on the very limited evidence so far, I would say those are the two avenues that seem most promising.
Thank you very much. We will not hold you to that, though.
Thank you. Appreciate that.
But let me ask another question. Is this disease somewhat like cancer, where the standard of care is essentially now being in a clinical trial?
Yeah, so many have argued that. In fact, when Ebola broke out, many people tried experimental therapies, and there was a very, I think, pointed set of conversations saying the only proper way, given the emergency, was to try to proceed with a study, a trial, because we don't know if treatments are helpful or harmful. And this is really the only ethical approach. And I think the tension, as I mentioned before, is when you don't have trials available, do you as a clinician feel like you should just try something? It's that old admonition that I tell medical students: just don't do something, stand there. That standing there may be better than doing something, but in the great American way, people feel better in control by doing something. And I think that's a hard impulse to fight.
Yes, thank you very much. That is very true. A question from Armin Nauruzapur. Any thought on the Japanese antiviral favipiravir?
Yeah. So this is an anti-influenza drug, and has had some interesting in vitro data, and has been discussed as potentially helpful. I don't believe there's been quality data yet. It may work a little differently than our current FDA approved drugs. Oseltamivir probably shouldn't work, because that works on a neuraminidase molecule, which is really not present or needed for this infection directly. And baloxavir, which is a new anti-influenza drug, is a NCAP endonuclease inhibitor, which also probably doesn't work. But the Japanese drug is just a straightforward mRNA RNA polymerase inhibitor, so may have some role. So we'll see. I mean, that's something I think in the next month or two we may hear more of.
Yes, thank you. We'll look forward to that. A question from Mario Rugna. Which is your actual suggested therapeutic option for the early, moderate, symptomatic COVID patient?
Yeah. Well, right now, nothing. I think it would be supportive care. You wouldn't qualify for remdesivir under an EUA. Enter a clinical trial if it's available. most people do well with supportive care. I mean, fortunately, they're very high risk people. We don't know who's predictive, but those would be my recommendations. I would say we have used tocilizumab off-label for patients, and we have some indications that it looks like it might be helpful. But again, this is in an uncontrolled environment. Very hard to know how we're choosing these there. So perhaps using a drug that's inhibits inhibits IL-6, I might consider. But again, it's still based on very slender data, mostly case series or anecdotes, which always makes me very uncomfortable. But I'm not quite as, I guess, as dogmatic as those that say absolutely only an RCT, especially if you don't have access to anything in your system. But I think your patients should clearly know the risks and the benefits.
Certainly, thank you. A question from Karen Rhodes. Any thoughts regarding the Kawasaki-like illness in children that has recently garnered significant publicity?
Yeah, we don't know if it's like garden variety Kawasaki yet, or at least I haven't seen that. I'm not a pediatric ID person, but that's Kawasaki's has always been thought to be triggered by a virus or occasionally by respiratory infections. So this seems no different, whether it's some variation. It's interesting, of course, that children generally have not been severely ill and was not really described in the early China experience, but we're seeing it in Europe and North America. Speaks to perhaps some genetic differences. We don't know yet. But this is yet another fascinating aspect to it that does give some pause. And we have to see if the treatment for Kawasaki's is the same, interestingly, for this disease, although I suspect it probably will at least be viewed as such. So yeah, no, I mean, all I can say is this virus continues to amaze me as we learn more and more as we move along. Think about where we were 3 months ago, 4 months ago, thinking this was pretty much an influenza-like illness, and where we are now, this is not influenza.
Yeah, very true. A question from Marco Silvilati. Your thoughts on the limitations of using viral RNA shedding as a surrogate endpoint, and how to interpret the findings of trials that rely on this measure as an indication of efficacy?
Yeah, so I think it depends on the trial. Raising a very good point that we know that at least at data that I'm aware of from people that are not that ill, the virus can shed for 3 or 4 weeks, right? So that doesn't mean they didn't improve and so on and so forth. Now, it is a surrogate marker, and if you can generally turn off the virus early on in the first days of illness, I do think it's important. Whether it's important at day 14 or 20, I think it's less so. There's just probably less impact there. And again, I hate to keep bringing up influenza, but those are the quality studies I know. For example, oseltamivir given within 6 or 12 hours of onset of symptoms, people improved by 3 to 4 days and had marked decrease in viral carriage compared to those that took it at 48 hours, for example. So I do think it does have a role. However, I'm much happier with clinical endpoints, whether it's mortality, whether it's mechanical ventilation, even length of stay. Any of those to me are in this disease at this time frame more important than just viral carriage. But that's much easier, and why you got so much press, and why hydroxychloroquine and azithromycin got a lot of traction early on based on very small numbers of patients, like 6.
Yes. One final question, I believe. What is your current practice for patients that are stable enough to be treated as an outpatient? Is there anything beyond supportive care for these patients?
Yeah, unless if you're in a clinical trial, I'm not aware of any outpatient recommendations. Certainly, you would not qualify for remdesivir under the EUA. There are clinical trials looking at the ambulatory population or the, the less ill population. So if you are in an area, that may be an avenue to seek. Again, you don't know if you're going to get the active arm or not, but would be helpful to try to understand what we can do for our patients. So I always encourage people at this stage to enroll, and there are increasing numbers of centers now that the panic and pandemonium and chaos that really we were all grappling with early on is now a more organized chaos. And we're doing, and I'm sure as Dr. Rothman and others will testify, we're actually launching studies and enrolling patients when that was not the case in March.
Yes. All right. That is the last question we have time for today. Thank you again to Dr. Auwaerter for sharing your incredible stories and for helping the rest of the country prepare just a little bit better for the COVID-19 pandemic in their own EDs and hospitals. Dr. Rothman, do you have any final remarks?
I just wanted to thank Paul for the time that he put in and putting everything in perspective for us in the emergency department. There's obviously a lot going on. I think from an ED perspective, like Dr. Auwaerter mentioned, I think there's opportunities and important roles we can play in emergency medicine, partnering with our infectious and critical care colleagues going forward as some of these trials take off, both from the inpatient side and the outpatient side. I think there's a lot of excitement in terms of being able to potentially make a big impact on a disease with a high morbidity and mortality. And I think from the standpoint of us and the society and us individually in our own academic centers, I think we should look for those opportunities to participate, both to help with individual patient care as well as for the health of the public. So thanks again, Dr. Auwaerter, greatly appreciated. No other comments.
Well, and thank you for listening. I want to thank everyone for really being at the tip of the spear here in terms of all the patient care and work with this pandemic. Thank you.
Thank you very much. It's our pleasure to have you speak today. Thank you again to all of our speakers and to all the viewers for joining us today. This concludes our keynote address and special COVID session for today. In a few moments, we will begin our plenary abstract presentation on SAEM's YouTube channel and Facebook Live. We hope you will join us there now. Thank you very much.
Hello, I'm Zach Meisel, and thank you to SAEM and to you for this opportunity to give this plenary session. I'm going to present the Life Storied study, Stories for Opioid Risk Reduction in the Emergency Department. This was a comparative effectiveness study of 2 individualized acute pain treatment communication tools. There are no commercial disclosures. This study was funded by PCORI, the Patient-Centered Outcomes Research Institute, and my time is also funded by the CDC and the NIH. I wish to thank an amazing team who helped make this massive study possible. The team included co-investigators, patient investigators, storytellers, filmmaking team, as well as an advisory board members and large study staff. In particular, this study is dedicated to the memory of Paul Yaber. Paul was one of our storytellers who discussed so candidly his experiences with pain treatment as well as substance use disorder in an effort to help people better understand their risks and make more informed decisions. Tragically, Paul died just weeks after sharing his story for the camera as part of our study. Here is Paul's story.
I came down with a condition called peripheral neuropathy that affects the nerves in the hands and the feet. It especially impacted my feet, very hot, burning, painful, like needles in the bottoms of my feet. An opiate-based pain medication, Oxycontin, was suggested to me. And at first it worked very well, but I began to abuse it. I had some experience with casual drug use, marijuana, social drinking, even snorted a couple of lines of cocaine somewhere along the line. My mother was an alcoholic, and my father was also an addict. But I was never prepared for the impact of abusing prescription opiates had on my life and the dark path it led me down. In the beginning, I thought I really had it. It was okay to take a couple of pills, even to crush one up and snort it. No big deal. You know, I could handle this. What I felt at first was euphoria and relief turned into a constant state of paranoia that I'd run out of pills or not have the medication nearby so I could take it when it desired me to take it, because it kind of took on a persona of its own. And it was just an avalanche after that. Things got worse. I would run out of pills and have to search for more and scrounge up money, and eventually led me to heroin abuse. I slowly disintegrated, and I didn't realize it. I didn't realize how sinister the process was, how secretive it was. And I lost myself in a slow manner that I didn't even recognize. So I lost my girlfriend, lost my car, lost my house, lost my license, went to prison, destroyed my relationship with my family, and eventually I acquired HIV.
Paul's story sets up a key challenge to patients and providers. What are the best ways to communicate opioid risks to patients with pain and align their preferences and values while not exposing them to additional risks? The objectives of the study were to compare the effectiveness of 2 individualized opioid risk communication tools using 1, a visual display of one's opioid risk misuse, and 2, a visual display of one's risk of opioid misuse plus a narrative enhancement video like the one you just saw, and 3, a generalized risk communication sheet, which is usual care. At a high level, we sought to compare the effectiveness of these tools on patient-centered and reported outcomes for emergency department patients who present with acute back pain or kidney stone pain. This was a multi-centered randomized clinical trial performed at 4 geographically diverse emergency department settings. These were our inclusion criteria and exclusion criteria. This schematic demonstrates our enrollment and data collection protocol. Patients were approached in the emergency department after being evaluated by their treating physician. If they were deemed likely to go home and determined to have back or neck or kidney stone pain, they were then enrolled and randomized to receive one of 3 interventions, which I will describe next. Baseline data were collected as well as follow-up data on days 1 through 6, then 7, then 14, and again on day 90, using a patient-reported outcome web-based data collection tool called Way to Health. The usual care arm received a standard patient information sheet about their condition. We assessed patients' baseline opioid risk using the previously studied opioid risk tool assessment called the Opioid Risk Tool, or the ORT. We then translated that risk into an automated infographic for different risk categories. The infographics leveraged the use of a visual thermometer-like scale and the use of probabilistic communication methods known to be effective in risk communication. It provided basic information about why and how the risks were assessed, as well as some information about options and encouragement to discuss them with a provider. Each participant in the two individualized risk communication intervention arms, as well as the treating provider, were shown their risk assessment. Participants in the narrative enhancement arm were shown the probabilistic risk tool and also provided an opportunity to view short, real stories from study partners who described their experiences with pain and pain treatment, and sometimes substance use disorder. Not all the stories were about addiction per se, but all involved a description of individual risk, pain treatment, and they all had a narrative arc. Participants in this arm were encouraged to watch at least 2 video vignettes in the hospital, and they had the option of watching more at home. Pre-specified outcomes assessed were risk awareness and recall, the presence of opioid medication use at day 14, the preferences for opioids upon discharge, and satisfaction with pain treatment 1 day after the ED visit. 1,302 patients were randomized 1:1:1 across all 3 intervention arms. The day 14 response rate was approximately 70% and was equal across all 3 treatment arms as well. Here are the baseline characteristics. We enrolled about 3 times as many patients with musculoskeletal pain and back pain compared to renal colic. There was good distribution across gender, race, and ethnicity. Randomization worked well, and there were no significant differences by baseline characteristics across the treatment arms. There were no significant differences by treatment arm in each risk category for opioid risk. Approximately 1/5 of all the enrolled patients were ultimately prescribed opioids in the emergency department. And now for the main results. Recall of opioid misuse risk score was assessed only between the probabilistic and the probabilistic plus narrative enhancement intervention arms. 39% of the participants in the probabilistic arm recalled their risk score, and 44% in the probabilistic plus narrative group recalled their risk score at day 14. This difference was not statistically significant. However, we pre-specified that this risk recall effect may be most prevalent among the high and highest risk scoring participants. And indeed, we found a 22% difference between the probabilistic and the narrative arms in terms of recalling their risk in the high and highest risk group. This was statistically significant. Preference for opioids was an additional primary outcome, and here we included the GRC, or usual care arm, in our analysis. 33% of participants who received usual care requested opioids, whereas 28% in the probabilistic and 20% in the narrative arm preferred opioids. These differences were significant even when adjusted for type of condition, as well as opioid risk score and demographic characteristics. Again, here, the narrative enhancement appeared to have the strongest effect in reducing preferences for opioids. By day 14, 11.4% of the participants reported still taking opioids, either from their original ED prescription or a new prescription. Here is the breakdown by treatment arm, with the risk communication arms reporting differences that were not statistically significant. We measured patient satisfaction with pain treatment. This was captured at day 1 after the emergency department visit, and on a scale of 1 to 10, in this analysis, the narrative group reported significantly higher satisfaction at 7.3 compared to the probabilistic only and the usual care participants at 6.6. So here are our key takeaways. For patients who present to the emergency department with acute back, neck, or kidney stone pain, there may be some benefits to assessing and showing patients their own individualized risk score for opioid misuse. These benefits manifest in terms of reduced preference for opioid use, patient satisfaction, and recall of their individualized score 2 weeks later. We did not see any differences in opioid use at day 14, but among the other effects, there do appear to be differences, with the strongest effect being seen among the group that received the narrative or storytelling enhancement. The stories we used were real stories told by patients with complicated and emotional experiences that were shared in a brief online format. There may be future opportunities for these types of interventions for risk communication and shared decision-making scenarios. Please watch and use the stories that our patients shared as part of our study. Thank you so much.
Hi, I'm Dr. Jennifer Weiler, Professor of Emergency Medicine and Business at the University of Colorado, and I'm presenting on behalf of Kirsten Rounds, Becky McGowan, and Jeanette Baird. Our project was entitled Disparities in Gender, Representation, and Salary in Emergency Medicine Leadership Roles. This initial data was presented at the Association of Academic Chairs in Emergency Medicine and the Academy of Administrators in Academic Emergency Medicine annual retreat for each of the years that the data was collected, as well as the SAEM annual meetings of each of the included years. We had no financial support, and none of the authors have a conflict of interest to disclose. Emergency departments have had a variety of formal leadership roles. This study seeks to determine if there are a gender gap in leadership roles and in the associated salaries of women in those leadership roles. A secondary aim was to determine if there's a gender difference in the domains of roles held by emergency medicine physician leaders. This was a successive, cross-sectional observational study of U.S. emergency departments using the Association of Academic Chairs in Emergency Medicine and Academy of Administrators in Academic Emergency Medicine member surveys from 2013, 2015 through 2018. The descriptive statistics are reported and assess differences in gender representation and salary, which was conducted using linear generalized models with rank, years as faculty, region, clinical hours worked, and academic versus community ED as covariates in our model. Separate regression models for male and female salaries across time and leadership roles were also estimated. There were 9,620 responses from 154 academic and community emergency departments. Female emergency physicians represented, on average, 34.4% of responses per survey year. Across all survey years, the percentage of women in leadership roles was significantly less than men at 44.5%. Women were least represented in executive leadership roles across the 5 survey years at 9.7% as compared to males. But females were noted to be significantly more represented in educational leadership roles at 18.5% versus 13.7%. Within each leadership role, after adjusting for model covariance, female salaries were significantly less than males, and although salary growth was significant over time for both males and females, females in leadership roles had a significantly lower salary than males at each of the 5-year time points that the data was reported on. These salary differences averaged across the 5 years and were $57,150 for executive leadership roles, $27,280 for operational leadership roles, and $19,177 for educational leadership roles. Based on this study, we conclude that across the United States, There's a significant lack of women in emergency medicine leadership roles, and in particular, executive leadership positions. We also find that there is a large, unexplained salary gap in all leadership domains, which is currently, again, unexplained. Thank you.
Hello, everyone. My name is Craig Newgard. I'm an emergency physician at Oregon Health and Science University in Portland, Oregon, and I am honored and privileged to be able to present our work to you today. I also want to first recognize, support, and thank the many emergency care providers throughout our country and truly throughout the world. So all the physicians, nurses, APPs, techs, medics, and everyone else, thank you for your service and all your care in these last few crazy months. I present to you a national evaluation of emergency department pediatric readiness and outcomes among U.S. trauma centers. I want to recognize my many important co-authors in this work. We are funded by a grant from NICHD, have no further disclosures. There are 10 academic medical centers participating, as well as 5 national organizations and 13 state departments of health. This is truly a large collaborative effort. First, some background. Unintentional injury is a leading cause of death and years of potential life lost in children. Most of these children are cared for in emergency departments. And over a decade ago, the National Pediatric Readiness Program was stood up to measure, understand, and improve the emergency care delivered from EDs, and in particular, be able to grade and score the capacity and capability of EDs to provide high quality care for seriously injured and critically ill children. It turns out that there's large variability in this readiness to care for children. And while EDs and trauma centers are assumed to provide comprehensive high quality care as part of the most sophisticated regionalized model of care in the world, this is not entirely clear that all EDs reach this benchmark. And several important questions persist. One in particular, it remains unclear whether increased readiness in the ED actually improves quality and health outcomes in our children. This, we sought to evaluate the association between ED readiness, mortality, and complications among injured children presenting to EDs in U.S. trauma centers. This is our conceptual model. There's an injury event in which a child is involved. They are transported to the ED. The readiness of that initial ED is quantified through a national readiness survey. We track children through their hospital course, whether or not they're transferred to another ED or hospital, and then measure health outcomes and quality measures. To do this, we included 44 states from 2012 through 2016, representing 841 trauma centers of a variety of levels, which participate in the National Trauma Data Bank. We match these data to the National ED Pediatric Readiness Survey and focus on children 0 to 17 years with trauma who were admitted, transferred, or died in the hospital due to trauma. We also linked a portion of these records to state vital statistics records, which were validated in 5 states. The readiness survey was conducted from 2012 through 2013 in all 50 states and U.S. territories and included 57 questions in 6 domains. These were created by multiple national organizations and an expert panel to, again, represent multiple aspects of the capability and readiness of caring for children. The answers to these questions are then translated into an overall score called the Weighted Pediatric Readiness Score, which ranges from 0 to 100. And this was the primary measure that we evaluated for looking at ED readiness. We collected a number of patient-level variables, all which are included in standard risk-adjusted models for trauma, as well as several hospital-level variables. Our primary outcome was in-hospital mortality or serious complication. You can see the complications listed here. For secondary outcomes, we looked at in-hospital mortality, and then for a subset of children, mortality out to 1 year. For our statistical analysis, we used probabilistic linkage to match records from the initial ED to a second ED or hospital for those children who were transferred, and also to link in state death registries for a subset of states. We looked at key subgroups of children using a variety of definitions of serious injury, and we scored pediatric readiness by quartile at the ED level. We used random effects regression models, which were clustered on the initial ED, and several sensitivity analyses to test the rigor of our findings. This is a schematic of our cohort creation. We included any child for whom we had information from the initial ED, including a matched pediatric readiness survey. The only children that we otherwise excluded were children who arrived with no signs of life. Our total cohort included 312,790 children, which also included just shy of 47,000 children who were transferred to other facilities. Patient characteristics are listed here. There were just under 3% of children who had our composite outcome of either death or complications, and the subgroups are listed here. This is a histogram at the ED level measuring quartiles of pediatric readiness. And we can see that there's a fairly large spectrum of readiness across these trauma centers. I will also note that the lowest quartile of readiness, over 30% of these hospitals were level 1 or level 2 trauma centers. These panels illustrate the unadjusted rate of outcomes on the weighted pediatric readiness scale. So we can see that on the low end of the scale, there's more scatter, suggesting a higher rate of complications or in-hospital mortality. However, these findings are not adjusted for important confounders and predictors. These panels present findings that are adjusted for those predictors and confounders. These come from our multivariable models and represent the odds ratios of the composite outcome or isolated to in-hospital mortality, looking at different quartiles of readiness compared against children who were seen in the lowest quartile of ED readiness. If I draw your attention to the upper left panel, we can see that for the composite outcome, this suggests a lower odds of adverse outcomes. However, the confidence interval just touches 1. When we look at mortality, this effect is more statistically conclusive. It would translate into a 42% reduction in the odds of mortality for children seen initially in high readiness EDs compared to low readiness EDs. The other panels look at the variety of subgroups by injury severity, and we can see that these findings are also quite consistent across different subgroups. This slide looks at the different domains of readiness in similar risk-adjusted models, and we can see that the personnel domain is the one that stands out as having the strongest association with improved outcomes. Personnel represents the training, background, and evaluation of providers, both physicians and nurses who staff the ED. One-year mortality analysis included just over 40,000 children. We can see in comparing in-hospital to one-year mortality that there were some children who died following hospital discharge, but prior to 1 year. And when we run the same models on this subset of children for each of the same groups, there is one subset that stands out, that is retaining that beneficial effect in reduction of mortality out to 1 year for the association with being treated in the highest quartile of ED readiness, and those were seriously brain injured children. Sensitivity analyses are represented here. We can see that for the composite outcome, as we add in trauma center level, pediatric trauma center level, and volume, the confidence intervals widen slightly to make these findings less statistically conclusive, but for mortality is very persistent despite adding different hospital level variables. That is, the effect of mortality persisted in all the sensitivity analyses. There were limitations in this study. We focused on a higher acuity population that's limited to children with trauma. Our Findings also reflect that of U.S. trauma centers, which may not represent all U.S. EDs. We also focus primarily on in-hospital outcome with a subset of children. In conclusion, injured children admitted through high readiness EDs had lower mortality and possibly lower rates of complications when compared to similar children cared for in low readiness. To translate this more simply, our results demonstrate that the initial care really matters for injured children. These findings support national efforts to raise ED pediatric readiness among U.S. trauma centers that care for children. This might be done by integration of pediatric readiness into national and state level verification programs for U.S. trauma centers. Thank you for your attention.
Hi, everyone. My name is Brandon Allen. I'm an emergency physician and a primary investigator for the STOP-CP research study. I'm humbled and honored to be able to present our abstract as an SAEM plenary, which is titled One and Done, Performance of a Single Low High Sensitivity Troponin in a Multi-Site United States Cohort. Some of our pertinent disclosures for this, as you can see, some of very renowned researchers in emergency medicine are a part of this study group, and they've done research both with industry as well as federal funding. A little bit about the background of chest pain. It's no secret to you guys that 15.5 million people in the United States suffer from cardiovascular heart disease. And the American Heart Association reports that a heart attack occurs every 41 seconds in the United States. Heart disease is the leading cause of death in the United States. And chest pain is among the top reasons for emergency department visits. A little bit more about the background of our study and the primary objective. We used the high sensitivity troponin T assay. This was FDA approved in January of 2017 as the first high sensitivity assay. Now, it's titled Generation 5 assay by the FDA because it did not meet all of the criteria by the IFCC for high sensitivity. However, for this study, we used cut points below the limit of quantification, which is in line with European data. So there's a couple of key definitions that are important to know, and the limit of quantification is the lowest number that's able to be recorded for the assay. The limit of detection is the lowest number that's able to be seen by the analyzer. And for this study, we use the limit of quantification, or the LOQ. Furthermore, starting as early as 2010, Europe data suggests that a single high sensitivity troponin result below the limit of detection excludes major adverse cardiac events, or MACE, in patients with symptoms concerning for acute coronary syndrome. However, the United States and the FDA limits high sensitivity troponin numbers to the limit of quantification. And there's a paucity of US data and lack of multi-center data in the United States to support any practice change based off of that. So this goes to our study objective. The objective of this study is to test the diagnostic performance of an initial high sensitivity cardiac troponin T measure below the LOQ in a multi-site US cohort. Can we answer the question of high sensitivity troponin, one test and safe for discharge or done? A little bit about the overall STOP-CP study. You guys have probably been wondering what STOP-CP stands for. Well, my co-primary investigator, Dr. Simon Mahler, coined the term based on the acronym, High Sensitivity Cardiac Troponin T to Optimize Chest Pain, STOP-CP. So for this study, we had a prospective observational cohort group, and we looked at 8 sites across the United States, and the patients were assessed based on the chest pain or symptoms suggestive of acute coronary syndrome. It lasted from late January 2017 to early September 2018. Here's our map of the respective sites across the country. As you can see, the Midwest was not present on our enrollment sites because the sites that we approached were already on the high sensitivity troponin T, which excluded them from being an enrolling site. Our study inclusion and exclusion are quite basic for cardiac biomarkers research, nothing out of the ordinary. Exclusion criteria of STEMI, of course, shock, and lack of capacity to consent and lack of follow-up. I think it's important to describe how we ran the STOP CP study, so then we can get into the actual abstract data of the one and done strategy and the assessment of its performance. So for STOP CP, we had an ED arrival, and if they met inclusion criteria after screening, they were enrolled. Well, one of the challenges is that the respective sites were blinded to the high sensitivity troponin result. So we went with the contemporary assay of those respective sites, and we tried to get the enrollment or high sensitivity assay for the study as close to the contemporary assay as possible. And we gave ourselves a window of 1 hour. We did serial troponins for the study at 0, 1, 2, and 3 hours. But in respect to this plenary presentation, we're going to focus on the first or time 0. After the initial blood draws in the index visit, which was reviewed, the providers at the bedside were asked to fill out a treating provider survey, which gave us information about clinical decision rule data, as well as the onset, quality, and character of someone's chest pain if it was indeed present. Following that, they had a follow-up review with a phone call and medical record review. It's also really important to point out how we got to our outcomes, and this is through adjudication. We used both cardiologists and emergency physicians to review the cases of these patients with the contemporary assay as well as the high sensitivity troponin with the primary outcome of MACE, or major adverse cardiac event, at 30 days. This was also with the secondary outcome of cardiac-related death, or MI. Cardiac-related death was based off of the Accord trial definition, and cardiac revascularization was based off of a CABG or PCI. It's also important to point out that we used the 4th universal definition of MI, which helped the adjudicators differentiate from a type 1 and type 2 myocardial infarction, which was a part of their study definitions and guidelines. The statistical analysis for this plenary abstract is that we use basic statistics of negative predictive value and sensitivity with exact 95% confidence intervals. For the overall STOP CP study, we enrolled nearly 1,600 patients, and we excluded about 120, and those were mostly secondary to lack of a second troponin at the study site, or that we couldn't get them in a timely manner. The patients eligible for analysis for STOP CP was 1,462, and we only lost 64 to follow-up, or a little under 5%. The primary outcome of 30-day MACE was included in 14.4% of this group, and in comparison to other U.S. studies, our event rate is actually higher and in line with what European studies have cited in the past. Instead of a big, busy table, we decided to come up with bullet points for what are the study characteristics of the larger STOP CP study in those over 1,400 patients. Well, 46.3% of them were women, 37.1% were African American, and the mean age was almost 58 years old with a standard deviation of nearly 13 years. In regards to this abstract, we wanted to look at the distribution for the patients under the limit of quantification. And as you can see from these numbers in the pie chart, a third of the group from the larger STOP CP study were included in where their first troponin was under the limit of quantification. This is not insignificant. And for that group, we found that they're likely to be female, younger, and more likely to be Hispanic or Latino, which was statistically significant. Okay, now let's talk about the performance of the assay at or below the LOQ. So on this bar graph here that you see, black is the 30-day MACE, and red is the death or MI at 30 days. The negative predictive value for 30-day MACE was 98.3%, under 99%. And for death and MI, the negative predictive value was right at 99%, but the confidence interval, the tail, looks to be lower than that. And for the sensitivity, they're both under 98% or 99%, respectively. Shown in a different manner, the dotted line on this graph is the LOQ for the United States for high sensitivity troponin T at 6. What this actually shows is that under 6, we likely have a very safe assay with a true 99% negative predictive value for both MACE and death or MI. However, as stated earlier, the FDA will not allow us to report under 6. at this time. But for Stop CP, we recorded down to 3. So that's how we have this data here where it looks like the actual sweet spot of safety is at 4 or less. All studies have some limitations. Some people may consider these strengths, maybe weaknesses. One is that sites were mostly urban academic centers. Our cohort had a higher MACE or event rate than many prior US studies. Our loss to follow-up was only 4%, which in most studies, it's 10% or more. We see this as a strength. However, for those 64 patients that were lost to follow-up, we don't know their event rate, so that has to be in consideration as a limitation. And also, we only utilized the Roche high-sensitivity troponin T assay. This was not a comparative study with other assays, including high-sensitivity troponin I. In conclusion, use of a single high-sensitivity cardiac troponin T measure below the LOQ may not be sufficient to rule out 30-day MACE and had insufficient sensitivity for 30-day cardiac death or MI. I think what this shows is that we probably need to mirror what Europe has done and report down to the limit of detection if possible, where I think we have a safer safety profile, which would also lend itself to what the European Society of Cardiology guidelines suggest. This study has many people who need to be acknowledged for their efforts. First and foremost is the University of Florida as the coordinating center and primary site. Couldn't have been done without the great research coordinators and team we have here. My co-primary investigator at Wake Forest, Simon Mahler, as well as our great site PIs, Dr. Rob Christensen, who did the central lab and all the analysis, Dr. Troy Madsen at University of Utah, Dr. Bryn Mumma at UC Davis, Dr. Richard Nowak at Henry Ford Health System in Detroit, and Dr. Gentry Wilkerson at University of Maryland. Also, this study wouldn't be possible with the data without our data manager, Scott Cohen, and our biostatisticians, Dr. Michael Weaver and Kai Yang. And lastly, I really want to thank the fellow emergency physicians in the midst of this pandemic and COVID-19. You guys may have thought that this is actually a pocket square, but it's my surgical mask when I have to walk back across to my office. And we've all had great sacrifices in the midst of this. I really hope that in the future, we could do this in person and have the camaraderie and scholarship that SAEM is all about. Thank you.